Hello, thank you for joining us and welcome to our coverage of ESMO 22, live from Paris. Joining me, Dr Chetan Deshmukh. Thank you very much for joining us today.
Thank you.
Can you tell us a bit about yourself, your background, where it is that you do your research now?
Right. I'm a practicing medical oncologist in the city of Pune, which is about 200 kilometers to the east of Mumbai. I have received my training in medical oncology from Tata Memorial Hospital, Mumbai, which is the apex cancer institute of India. And I practice at the Deenanath Mangeshkar Hospital and Research Center in Pune, where I conduct my basic service-related work as well as my clinical research. We are a 1,000-bedded hospital, which has a separate cancer wing. And we are now coming up with an additional cancer wing. And soon, 6 months down the line, we'll probably be doing almost every molecular test that is available. Cancer research is happening there since 2000-2001, and I've participated as a principal investigator in over 75 different clinical trials. And that is how I get to use some of the new molecules. And it's a very interesting field. It's a very challenging field as well. And I do enjoy it.
Well, today we're looking at some of the headlines in colorectal cancer. And to talk about your current practice, what is the treatment facilities and the treatment prospects like for people with colorectal cancer when they come to your clinic? Are they facing the same kind of advances that we talk about here today? What's the difference between ESMO and real life for you?
Okay, so for early stage diseases, I believe there is no difference. For early stage patients, we do the same treatment. It's either neoadjuvant chemoradiation or surgery directly, and then followed by adjuvant chemotherapy, which is pretty much the same what we see it all over the world. The standard adjuvant chemotherapy remains FOLFOX chemotherapy for everybody. For patients with locally advanced or metastatic disease, there is a slight difference because we have a challenge of having access to some of the medications. But in India, we have a fair amount of generics available as well. So quite a few monoclonal antibodies or even the targeted molecules are available. It's not that we don't use them. It's just that we use the number of patients on which we use them is a little smaller compared to the Western world. Also, the place where I work is a place which does not have access to any government-related insurance. So it's mostly a private-funded insurance or private insurance. So the number is low, but nevertheless, there is a fair amount of patients who do get these medicines.
Looking at some of the contents from the conference, one of the late-breaking abstracts was the Cairo-5 study of panitumumab versus bevacizumab with FOLFOX in colorectal cancer. And to kind of just compare the two arms of that study one by one, if we could talk out the molecular difference between the two medicines and how they had clinical impact. And then we'll look maybe from there to the broader medical impact and then maybe even the healthcare economic impact that they could have.
So traditionally, left-sided colon cancers were treated with EGFR-directed therapy, that is panitumumab, and that was a preferred molecule. But again, in those patients, we had to use these molecules only if you had a RAS which was wild type. So if you have a left-sided colon cancer with a RAS mutation, even then panitumumab is not going to be used. So in India, the preferred molecule was again bevacizumab anyways because of the cost, plus because of the access to RAS testing is pretty limited. Plus it's not only RAS, if you have a wild type RAS but you have a downstream RAF, then again your EGFR directed therapy is not going to be of much use, and in that case anyway you will probably have to fall back on bevacizumab. So the study results are pretty interesting that at the end of the day, the site, the molecule, the molecular subtype doesn't matter because ultimately both give the same result, and that is very important for us medically. Bevacizumab, we have been using bevacizumab first for ovarian cancer and then for various cancers, and we are very familiar with the molecule, the toxicity, the handling. I've participated in studies of bevacizumab generics as well as the original bevacizumab, and the drug is fairly easy to handle once you know which patients you are going to avoid bevacizumab. Say, for example, somebody has had an extensive bowel resection or intestinal obstruction, then such patients we avoid bevacizumab. But otherwise, hypertension, proteinuria, things which can be easily managed. Wound healing is not so much of an issue in the metastatic disease because you're not going to operate on these patients. So bevacizumab works out to be a pretty good option. So the study results are actually quite heartening for me. Right now, at least the place where I come from, India, the cost of generic bevacizumab is way lower than the cost of panitumumab. And plus, we have various patient assistance programs going on. So the cost is really, really not a problem. The cost almost is 25%, almost 25% of the cost of panitumumab. So for me, it's a no-brainer. It's a very straightforward thing. I can finish off chemotherapy even with a limited insurance. I can give the patient standard therapy. This study just strengthens my point that yes, bevacizumab is also good enough in these patients and it can be used without any issues.
And the session we've just come from was looking at whether novel immunotherapeutics or targeted therapies are going to transform colorectal cancer. And to give a simple verdict, yes or no, do you think that is likely to be the case?
I wish it was so simple as yes or no. Not now, not in the near future, for at least for me, not now or in the near future from now, for a couple of reasons. Well, the first talk about mutations apart from the RAS mutations, that was an interesting talk actually, because HER2-neu, ALK-positive colorectal cancers, these are important mutations and these are important targets for treatment of colorectal cancer. But we've had our tests done, we've analyzed our data, and the incidence of HER2 positivity in colorectal cancers is less than 5%. The incidence of ALK is probably even lower. Even in lung cancer, it's lower, so we don't expect it to be very high in colorectal cancers anyway. But for that one odd patient who has a HER2 positive disease, the treatment is really very simple because trastuzumab, lapatinib, these are combinations available. Even generic TDM1 is available in India today. So that's not a problem. So that is a very interesting study. Again, for ALK positive disease, we have a host of molecules, crizotinib, ceritinib, brigatinib, lorlatinib, all of them are available. So it is interesting. The numbers may be very small, but for that one patient, it may be an important decision and an important drug, and which may improve his quality of life, his survival, everything. So that was a very interesting talk and very heartening. The other talks about RAS mutation and RAS targeted therapy, well, to be very honest, it's a little futuristic right now because most of the drugs, the direct RAS targeted drugs, have not given such a fantastic response which we wanted them to be. We've in 2013-14, we had done a study on a monoclonal antibody against RAS mutants. And again, that molecule also did not do very well and the trial was a negative one. So right now, RAS targeted therapy, I'm just looking at it with interest. I would say, let's wait for some more data. Let's wait for some more studies to come out. And well, right now the discussion is all about overall response rate and survival and everything. These drugs can have nasty toxicities. Even earlier we thought that EGFR directed TKIs in lung cancer were simple. Once we came to know about their toxicities, some of their toxicities are pretty bad. So I'm just watching at all these RAS targeted therapies with a lot of interest, but I don't think they are even nobody claims them to be ready for prime time as of now. Maybe in the next few years to come, once we get better drugs, probably with a lesser toxicity, who knows? Yes. But right now, well, just interesting, but not for me. The third thing which they have said is about the use of immunotherapy. That is something. Especially the concept which really appealed to me was the idea of making a cold tumor hot and then using immunotherapy checkpoint inhibitors, which were giving a good response. That is one thing. The second thing, the niche study was, again, a very interesting one. For people with deficient MMR, well, the response rates are bound to be good. But they had fantastic response rates even in proficient MMRs. Now, that is something. So, it would be really worthwhile knowing more about these patients, these subgroups. Dostarlimab, well, the world is talking about it. We've had a fantastic response, 100% complete response in those patients, and it has been out. Even my breast cancer patients have called me to ask why they haven't been given this drug. So that's everybody's talking about it. But These, again, MSI high patients or patients with deficient MMR, these patients are going to be amenable to immunotherapy big time. And immunotherapy is catching up. The use is catching up in India. And in the next few years to come, I see a lot of patients being treated with it. To be very honest, we've seen responses to immunotherapy even in absence of serious adverse events. That was one of the case in most of the, that used to be the case in most of the tyrosine kinase inhibitors, that if you have a bad rash or really bad toxicity because of the TKIs, yes, you respond better. But with immunotherapy, we've had some patients who've sailed through immunotherapy, taken it for 2 years with very minimal side effects, a little bit of fatigue, a little bit of pruritus here and then. That's about it. No major pneumonia, no diarrhea, no colitis, nothing like that. No endocrinopathy. So I would say that, it not necessarily correlates with toxicity. If somebody has toxicity, you manage it. But even people without toxicity are doing pretty well. So I'm quite hopeful that probably these drugs, and we saw so many new drugs coming in. I mean, we just have, right now in India, we just have nivolumab, pembrolizumab, atezolizumab. So there are more and more drugs. Once they come in, we'll probably see better and better drugs with lesser toxicities.
With the 1-2 punch that's required for heating up a tumor and then treating that newly activated tumor, is there any combination that you see as especially promising, or one that poses perhaps a combined toxicity risk? If there isn't any adverse reaction in the first case, then maybe they are primed for a second response.
Possible. That's again an interesting idea that on the re-challenge you may see, or after a sequential therapy, there may be some different toxicities. But right now, the usage is very, very small. So we are right now pretty excited about the use in the first line itself. So probably we may see these things in the next few years to come.
Well, some of the mutations that we've mentioned are affecting, like you say, 1 or 2% of patients. Is there a chance that the broad approaches to managing cancer are likely to surpass the targeted treatments in the near future?
Well, right now, the number is small, I believe, is also partly because of the testing is not done as much as we want it to be. Like earlier on, people used to think that HER2 positive disease in breast cancer is about 5% in India. Gradually, they expanded the testing. And now we know that it's anywhere between 25 to 30% or even 32% in some centers. So that's pretty high. So I'm sure this concept will catch up. Right now, we are not doing testing because a lot of people believe that, if there is no drug, why should I test? But once we have a drug, and once a drug is available at a much patient-friendly cost, I would test it. Why won't I test colorectal cancer for HER2-neu? The center where I practice, testing is available. Why won't I test it? It's available. It's ready. The drug is there. The drug is not so expensive. I would test it. So as people test more and more, I'm sure the number will go up more and more. And targeted therapy, precision medicine is here to stay. I don't see all these things replaced only by chemotherapy. Certainly not in the metastatic setting, where patients value quality of life, where patients value the safety profile of a drug much more than just the efficacy of the drug.
Well, then, looking towards the future for managing colorectal cancer, it seems like there is a trial for every patient and for every type of tumor. How can we go about connecting those patients with the right trials for them, and hopefully with a prospect for the right kind of treatment for them as well?
Yeah, trials are coming up. And, I foresee a time when we'll probably have trials where n is equal to 1. We'll have one trial for each individual mutation. You never know. But gradually things are opening up in India, and access to these trials is also coming up. So a lot of our patients are getting access to these medicines through clinical trials. The only thing is the mindset, where participation on a clinical trial has to change. Well, even world over, I don't believe that the number of trial patients enrolled are anywhere more than 10% of the entire population. In India, it's probably less than 5%. It's just a thought that you are going to enroll yourself into a unknown medicine territory. And that is a fear which many people have. But that is gradually changing. It's easy to write in the guidelines that, well, the best option for this kind of a problem is a clinical trial, but actually participating in the clinical trial comes through a lot of education, a lot of counseling. We have patients now coming to me, they come to us asking for a clinical trial, that do I have a clinical trial? I'm conducting a clinical trial on a relatively rare disease. I got a patient who is in a different city. It takes 1.5 hours to fly from that city to my place. But that lady is willing to participate, and she wants to participate. She's willing to comply. So, this thing is going to come up over a period of time. People are going to participate in the clinical trial, and I believe that that's going to be the future. Unless you participate and unless you evaluate the data, we say that right now in India, a lot of people believe that whatever has worked in the Western population may or may not work in the Indian population. So they are wanting to do clinical trials of their own, and it's quite logical. The genomic profile may be completely different. Toxicity profiles may be completely different. To give you a very simple example, capecitabine is tolerated very easily by the Western population. In India, capecitabine is a terrible drug. Not many people tolerate it so easily. So people are looking at clinical trials. People are looking at getting their own clinical trials. A lot of investigator-driven research is also happening in India. And once molecular sequencing comes in a big way, I'm sure we are going to have a lot of clinical trials there.
A final thought to look more globally. You mentioned the difference in capecitabine between the Western world and in India. To look across lower middle income countries, generally, they contain a vast amount of the population, a vast amount of genetic diversity. What is the access and the value of the access of bringing those people into not just trials, but drug access and kind of participation in the way that they get a hold of medicines that the Western world can enjoy and possibly relegate to being a very expensive drug for very few people, where it could be serving a lot more people somewhere else to a tremendous value?
So the first thing is we have a whole lot of generic molecules which have been good, which have been tested against the standard molecules. They have been found to be equally effective. That data has been published. So we are very comfortable using those drugs in our patient population because those drugs have shown to be as good as the original one. And that access, the cost of trastuzumab, for example, when there was no generic available, the cost was close to about, I would say, 1,500 euros a dose. With with the generic one available, it has come down to maybe 200 euros. So the cost has come down to almost less than 25% of the original cost, and that has helped. That has helped a lot. Earlier on, HER2 positive patients, the patients under the who could afford anti-HER2 therapy was about 5%. Now it has gone up to 60-70%. In fact, in the next few years to come, there will be hardly anybody who doesn't receive an anti-HER2 therapy. It could be 9 weeks, it could be 6 months, it could be 1 year, but some form of anti-HER2 therapy is offered. Same is true about anti-CD20 molecules. So anti-CD20 therapy earlier was expensive, cost about 1,000 euros. Now you get anti-CD for maybe about 150 euros. So that kind of difference has been phenomenal. And that is where we have been trying to get more and more trials. So biosimilar trials are being done in India. The molecules are good. In fact, some of these molecules have been marketed outside India. So they are really good. They are really standard molecules, and that is why access has become easy. What we lack is the patient groups, patient support groups, and those groups which have been at the forefront of pushing for fair pricing of the drugs and helping patients arrange for funds. Those activities are really lacking in India. Right now, patient support groups are there in India, but they are largely on a social scale. Patients get together, patients share their thoughts, they share their grievances, and there's a little bit of supporting. That support is largely on a social front, that you need a patient listener to listen to your troubles. But I believe that there are patient support groups in Europe who actually help arranging drugs, actually help control the pricing of the drugs, the sale of the drugs. That kind of activity is sorely needed in India. So once that happens, I believe that in the next few years to come, we'll have access to most of the there'll be some odd innovator drug which is always going to be there still in the pipeline and will not be accessible to other countries. But that happens. But such patients where this new molecule is going to be very effective is going to be used in only a niche of patients. Majority of the patients are going to need the standard established molecules. And I believe that in the next few years to come, we'll have a situation where most of our patients will have access to it.
Sounds like a good future to look forward to. Dr. Deshmukh, thank you so much for your time today.
Thank you. Thank you very much.